right, Namita? So,
Namita, are you ready? Are you ready?
I am ready. There's this.
Is it okay now?
No, sir, it is echoing. I think you'll have to log out from
So
one.
I will leave from one.
Yeah.
Okay. Is it okay now?
Yes.
So I will share my screen now.
So wait for just 2 minutes once I start the introduction, and then you can share the screen.
No, let me just check it whether it's working or not.
Yeah.
How to minimize this? Yeah, okay, I'm there.
great. So, Nitesh, I think you can go ahead to let people in.
Yeah, you can let them in, and I just want to check my presentation,
Yes.
So I think now we are all alive to the delegates also.
Yeah, 1 second. Okay, now
Different platform for
can we share the screen now?
Nitish, your voice, volume once again.
Okay.
Can I
please
share the screen?
Yes, sir. You can share your presentation.
Yeah, one second. What I'm
Nitish, please guide.
I don't see my presentation there.
Sir, multiple windows open.
Yeah, I'm going to produce many.
Yeah, please minimize some screens.
Okay, looks better.
Yeah. Now you can open first your presentation.
No, I think it's open now. But can you see my presentation?
No, sir.
Not yet.
Not now. Not yet.
Sir, let Nitesh share the screen. Is it okay?
No, I want to
Sir,
have
वो उसमें problem होगा फिर वो yes.
If it is working, we'll work that way.
Yeah.
Because we can't maintain the flow. You understand?
I got it. Your point, sir.
Nitesh, have you made Sir admin?
Yeah.
Okay.
So I think I'm sharing, and let's see.
Sir, your Zoom window is.
Can you see the screen now?
Yeah, I can see. You just yes.
Great.
You make
Okay.
it full. Yeah, this is.
Now you can see the presentation?
Yeah,
Very
I
good,
can see,
sir.
sir.
Absolutely.
Very well. Very well.
Okay, so we are okay now.
Go ahead, Nitesh. Let the people in.
Yeah, please. So, Namita.
Yes.
Yeah. You can introduce to sir.
Good evening, everyone. I'm Namita Goyal, the CFO of Wayinia Life Sciences. Due to some personal reason, Dimple Mahajan is.
Oh, you're on mute, I think.
Sorry, I had unmuted myself. Good evening, everyone. I'm Namita Goyal, CFO of Wayinia Life Sciences. Due to some reason, personal reason, Ms. Dimple Mahajan is not available here, so I'll be the moderator of today's seminar. I welcome the eminent speakers for our today's webinar, Aquadex Therapy, a Paradigm Shift in Fluid Management, Dr. Nandkishore Kapadia, Dr. Rajasekara Chakravarthi. I also welcomed Mr. Laurence, Head of International Sales and Marketing from New Willis, formerly known as CHF, and all the delegates. Thank you for joining us today. You may please note any questions that you may have during the webinar, and we shall address the same during the question answer segment towards the end of the webinar. Though Dr. Kapadia doesn't need an introduction, being a well-known figure, but just to give a short brief, he is the Director of Adult Cardiac Surgery and Director of Heart and Lung Transplant, Artificial Heart Unit at Kokalabai Dhirubhai Ambani Hospital, Mumbai. Dr. Nandkishore Kapadia has over 32 years of experience in cardiac surgery with over 12,000 CABG and 6,000 other open heart procedures, 500 plus minimally accessed keyhole bypass surgery, 250 plus mitral aortic valve keyhole surgery, 255 plus heart and lung transplants, 160 plus ECMO and VAD implantations. Such a rich experience. I now request Dr. Kapadia to start his deliberations. Over to you.
Thank you very much for the kind words, and thank you for giving me this opportunity to share my experience, which excited me so much. I never knew about this till Mr. Sharma, he came and talked to me, and incidentally I had a patient. So then I learned so much about this. So very good evening to all of you. So as we know that the fluid overload is a big problem in day-to-day practice. And not only the cardiologists, but cardiac surgeons, but also the nephrologists, gastroenterologists, they deal with this every day. Now, as we know that to understand the causes and impact of hypervolemia, the fluid overload, fluid overload is not something that, like is because of the over ingestion of the water. It is just because the failure of the system. Whenever there is a cardiac failure, slowly the IVC pressure goes up, the renal venous pressure goes up, and that reduces the renal output, the urine output. We keep pumping the diuretics orally or intravenously, and the resistance to diuretic becomes quite apparent after some time. So now we are going to talk about how the Aquadex smart flow system can be utilized in such cases. So we have to understand the patient selection, the venous axis, anticoagulation, ultrafiltration blood flow, the rate consideration, and how to set up this system. These are all technical things I think someone from the company will talk about. As we know that just now I mentioned, the congestive heart failure is a big burden worldwide. If you see in USA alone, there are 5.5 million cases of cardiac failure, and 20% of them, they die every year. Indian figures are missing. Probably in India, we have about 4 times the work of that, probably about 20-25 million. So it is like a big elephant.
Recording in progress.
Many times we see the fluid overload after the cardiopulmonary bypass, which is used for the CABG or the valve replacement, in nephrotic syndrome and many other kidney diseases, particularly in diabetics, liver damage. Many cases in myocardial infarction because of the damage and reverse remodeling. This patient, they go into a sort of retention of the fluid. Also in many cases of septicemia and severe burns. Now, particularly pointing to the heart failure, just now I said that it is the leading cause of the hospitalization among adults above 65 years of age in USA. But I think, in my opinion, because of the accumulation of the aging population worldwide, now we do see many patients who are having non-cardiogenic cause of the cardiac failure. Meaning to that they have normal coronaries, but they are hypertensive, and because of hypertrophy of the left ventricle, they develop diastolic dysfunction, and many of them, they go into heart failure and they have hypervolemia. Now, whenever you treat such patient, they are hospitalized, they go directly into the ICU, they occupy the bed 3 to 5 days. And if you see, this is one of the strong predictor of mortality. Now, 25% of the heart failure patients will be readmitted within 30 days, which even with the best therapy is true in many of the developed countries. 50% of the heart failure patient will be readmitted within 6 months. Now, diuretic therapy plays a central role in the management of the fluid overload. And if you see that this particular medication is prescribed by physician, cardiologists, cardiac surgeons, diabetologists. So this is quite a drug which everyone is familiar. Even the patient talks about that. So whenever they have more edema on the feet, or they are having swelling in the abdomen in their term, which is because of the ascites, maybe because of the large liver, they manipulate their doses, they increase their doses. So we have the mixed outcome in this patient. The longer a patient is on diuretic, the less effective they become, because of not only the the resistance to the drug, but also because that the venous pressure keeps going up in the renal system. There is a high incidence of the poor diuretic response. 40% of them will show the poor diuretic response, 68% will show suboptimal response. And in our practice, we see it every day. High risk of rehospitalization. Just now I mentioned 24% of them may be readmitted within 30 days, 50% within 6 months. Now that will affect adversely the clinical outcome. So more the patient is in, like hospitalized in ICU or in the ward, there is an increased risk of worsening renal failure, accelerated kidney function decline, electrolyte imbalance, symptomatic hypotension, high risk of mortality. Now, clinical evidence on diuretics, I will not go into details, but if you see the dose trial, diuretic optimization strategic evaluation, 49% of the patient discharged with weight loss of less than 5 pounds, which is about roughly, I think, 2 kilo plus. 16% of the patient will be discharged with the vein gate, paradoxically. Now, ultrafiltration in heart failure patients shown to have no significant changes to the electrolytes. Very, very important, doesn't cause hypokalemia. Reduced neurohormonal stimulation, RAS definitely is reduced. It stabilizes or improves the cardiac hemodynamics. Restored diuretic effectiveness in patient, allowing from input response to the diuretic agents. Now, as we know that diuretics, when they are prescribed in larger and larger doses, it definitely affects them hemodynamically. Many of the patients, they complain of giddiness because of loss of fluid and electrolytes. 53% reduction in the risk of rehospitalization of heart failure compared to the diuretics. So if you compare the ultrafiltration in the patient, if diuretics are used in optimal dose, and if they don't respond, even in increasing dose, and we use the ultrafiltration, more than 50% patient will no more require rehospitalization. Early initiation of the ultrafiltration in this patient will show euvolemia or may decrease the hospital length of this stay. So when you use the loop diuretics to eliminate hypotonic urine, or any other diuretic for that matter, the ultrafiltration will definitely have a predictable removal of the sodium and fluid, which can restore the diuretic responsiveness. There will be no change in the electrolytes, particularly potassium and magnesium. More effective decongestion and fewer heart problems events, improved GFR efficacy, and improved outcome. So this system, if you compare with the CRRT, we require a very minimum flow, which is 20 to 40 ml per minute, depending on the venous axis. And approximate volume is about 35 ml. It can be done through the peripheral axis, but I think the best thing is to use a central catheter, either double lumen or 4 lumen catheter. As you see in the CRRT or dialysis or SLED, we require actually them to have a good blood pressure, because the circulating volume will be 100 to 300 ml. And they require a big central catheter or dialysis catheter. So if you see here, the criteria recommended blood flow in the Aquadex system is very small, 10 to 40 ml per minute, which is less than 1 ml per second. We can increase it every 5 minutes by 5 ml, or maybe depending on how they respond or what is their blood pressure and hemodynamics, we can adjust this, and we can run it over a period of 1 day, 2 days, or 3 days. The extracorporeal volume which is needed is very small. It's less than 50% what is required in CRRT. The replacement solution is not required. Other advantage is it doesn't cause electrolyte disturbances as compared to CRRT or slate. And see, many times the slate can be done only 6 to 8 hours. If at all there is a hypotension, the nervous nephrologist or technician will immediately stop it. While in Aquadex, it can be extended to 1 day, 2 days, 3 days very comfortably because the membrane will work and it will not cause any hemodynamic changes. So I won't go into details, but I will mention that it is a continuous ultrafiltration therapy for temporary or can be extended longer than 8 hours in patients who require hospitalization. It can be used in both adults and pediatric patients, but weighing more than 20 kilograms or more, whose fluid overload is unresponsive to medical management, including diabetes. All the treatment must be administered by healthcare. Definitely, it is done in supervision, under supervision in the hospital. So there are various studies which have been done, and these were the multicentric studies, which definitely shows that although the number of patients is not so big in first study, but more than 200, 188, and 224. But the positive results are that the ultrafiltration can be used safely. It produces greater weight and fluid loss than IV diuretics. So that is quite encouraging. And if you see the retrospective single center analysis of 335 consecutively acutely decompensated heart failure patients, which were treated with the rate adjusted ultrafiltration with the Aquadex flow system. And that was between 2009 and 2019. So this is a long period, over a period of 10 years. And we found positive response. The mean creatinine level definitely improved. The mean BUN, blood urea nitrogen, also improved. And definitely morbidity and mortality is reduced. So this is the 10-year experience with the ultrafiltration for the management of acute decompensated heart failure. And all patients had stable renal function at follow-up compared with the previous ultrafiltration trial, unload or CARES or OID. So real-world experience demonstrated that ultrafiltration compares favorably for heart failure, rehospitalization, renal function response, weight loss or volume loss. So it is very safe and effective strategy for decongestion. Now, other designs of the studies were unique and single center, very small prospective study on 20 patients also showed that the heart failure patient with volume overload and diuretic resistance, the UF before IV diuretics effectively and safely decreases length of stays and readmission. So there is definite clinical benefit which can persist up to 3 months or even longer. This is another study. I won't go into detail, but there was some controversy whether ultrafiltration can work or cannot work, but definitely it works. And fluid load overload in CV surgery, cardiovascular surgery, critical care patients. Here, this is a graph multi-center study. Again, volume overload was among the top 3 most prevalent causes for first readmission within 30 days and beyond 30 days. So after that, the readmission rate came down. Now, major postoperative complications are associated with significantly worse survival and longer stay of a patient in the hospital. Fluid overload has a significant association with the combined events of death, infection, bleeding, arrhythmia, pulmonary edema. Early identification of the fluid overload is essential to establish the adequate management in the cardiac patient, which is quite commonly practiced all over the world in the critical care. Now, during the Aquadex smart flow monitoring, there are various parameters which are monitored: SVO2, hematocrit. Whenever there is an issue that the hematocrit is going up, or technically, then we have to turn off the pump and adjust the flow maybe after 15 minutes. So this is very easy to be monitored even by nurse or technician. Now, patient selection, vascular access, anticoagulation flow. I'll just go into small detail. I won't go into long detail. So it can be done in practically every patient. And if you want to remove more than 10 pounds, or which is almost like 4 kilo, or in patient weighing more than 50 kilo or under 50 kilo. So it can be safely adjusted according to, but remember that the patient may have actual dry weight of 50 kilo before the failure. And if he's 70 kilo, we have to calculate that weight difference and adjust the ultrafiltration. So recommended, we have to use a beaker. This is a catheter which is visible on the right side, which is available on request in India. But you can use any large bore catheter which we are using for the dialysis. The same can be used, double lumen or triple lumen. Now, there are other catheters which are 7F, 8F, 8.5, but preferably 8.5 is better. Quad lumen is also available, but we generally have used triple lumen. Anticoagulation is definitely recommended to prolong the life of the filter. Heparin is most commonly used. And we keep the ACT to the range of about 160 to 180, just like ECMO protocol. And or PTT to the range of 80 to 100. For patients with whom traditional anticoagulation recommended are inappropriate alternative strategy currently being used include non-weight based heparin. So 303 to 6 mg per hour. Or ECMO protocol is very easy to be applied. You can use also continuous heparin infusion. You can prepare 25,000 units in 50 ml, and you can use just 1 ml per hour. Sometime the bolus of the heparin may be given before initiation of this therapy, which is either 50 or 100 mg. No, 5 or 10 mg unit bolus during one primitive dose. Alternative administered sites of the heparin. Actually, the citrate is not recommended due to its molecular size. So very easy protocol for the anticoagulation. The blood flow rate mostly adjusted is 10 to 40 ml per minute. And once the filter is in place, it can work for 3 days. And very steady and reliable blood flow is critical to achieve a successful therapy. So we should have a proper catheter. The fluid is withdrawn from the intravascular compartment, and which is actually refilled by mobilization of fluid from the third space. Now, therapy initiation consideration, recommended blood flow 20 to 40 ml. We had done actually 40 ml per minute, and there was no change in the blood pressure. UF rate can be 0 to 500 ml per hour, depending on our requirement, but it should not exceed the ERR. Okay, I won't go into this is detail. It's quite self-explanatory. In heart failure patients, many patients may have a blood pressure of 70 range, 75 range systolic, even on tons of inotropes. And they have periphery which is clamped down, it is cold, and these patients sometimes we may have a problem of venous axis also, central axis. So once the central line is in, after the ultrafiltration is over, the same catheter can be used for continuing either diuretic therapy or inotrope therapy. Now, ultrafiltration, titration consideration every 6 hours, evaluate the blood pressure, heart rate. So it is done actually in continuous monitoring setting in the ICU. Urine output also, we should not do excessive ultrafiltration because sometimes whatever the patient is making urine, it may totally disappear and it may cause worry to the, the intensivist or doctor who is taking care because there is no pre-filtration load to the kidney. Therapy discontinuation consideration, sometimes you have to discontinue it if there is evidence of poor tolerance of fluid removal, ultrafiltration rate under 100 cc per hour, or net negative under 1 liter in 24 hours. Now, The parameter, once you are satisfied the JVP, jugular venous pressure is dropped to 7 or 8, there's no orthopnea, patient is comfortable, there's no edema at the feet, there's no oxygen requirement, and we can discontinue that. Now, persistence elevation in serum creatinine about 1 milligram per deciliter about baseline at the start of IV diuretic treatment, and persistent hemodynamic instability. So probably you have to discontinue this. So the therapy consideration is based on this fluid, means frequent admits for the volume overload, increasing creatinine, unresponsiveness to the diuretics, inadequate urine output, and the dry weight more than 10 pounds. But we have to stop if the serum creatinine continues to rise despite reducing the ultrafiltration rate. The therapy goal is achieved, oliguria despite reducing UF rate or pressure, patient not tolerating therapy, which happens very, very occasionally with this Aquadex system. So in summary, Aquadex smart flow system is a simplified form of ultrafiltration that can be prescribed to any patient by a physician. Any trained person can do it. Easy to set up and monitoring, allowing 4:1 patient ratio. So in ICU setting, one nurse can look after 2 or 3 patients or even 4 patients simultaneously. Approximately 35 ml of extracorporeal blood volume is needed. No clinically significant change in the electrolytes. Now here, the smart thing is when you calculate the blood flow rate, 10 ml to 40 ml, what happens, you can achieve the ultrafiltration rate of 120 ml per hour. So example, 10 ml per minute means 600 ml per hour. And you can remove 125 ml of fluid, which is 20% of the flow. If you calculate it, the bottom 40 ml is, will be 500 ml per hour ultrafiltration. So I had an interesting patient which I wanted to share, and this is quite a unique case. And Aquadex technology allowed me to successfully operate this extremely complex case, which was like fourth time redo open heart surgery. And this was a 32-year-old male who had heart surgery done in USA twice for tetralogy of Fallot. And then he had a lot of pulmonary valve regurgitation. So second time and third time, he was operated in India. So first time BT shunt, then total correction, and then again redo for the pulmonary regurgitation. Then incidentally, he was found to have hypertrophic cardiomyopathy with severe mitral valve regurgitation. So mitral valve annuloplasty was done in Chennai. Slowly, he started decompensating with severe pulmonary regurgitation and severe, moderate to severe tricuspid valve regurgitation. So this patient actually was just neglecting for last 7-8 years and continuously going into heart failure. So in 1996, he underwent the third heart surgery in Chennai, India, to get his one of the valve repaired. He then had few peaceful years. His heart continued to get enlarged and was rapidly failing with severe TR, pulmonary valve regurgitation. And incidentally, he developed very large aneurysm of the right ventricular outflow tract. His both legs were swelling, abdomen was distended with ascites, and practically he had fluid accumulated all over his body, importantly around the lungs and heart. His bilateral varicose veins were bleeding off and on. This had consequences on his daily routine, so much so that he had to quit his job as a pharmacist, closed his pharma shop. Diuretics were not working. He was on 4 diuretics. And he was admitted somewhere in ICU on larger doses of inotropes. And there was no effect. So he was bedridden in very hopeless condition. He's an unmarried guy. He thought of even committing suicide. Creatinine was rising. It was about 3.5. LFT was deranged. Liver had grade 3 fibrosis. He was contacting several cardiac centers across India and USA, but he was told that the 4-time open heart surgery is not advisable and there is a risk of death on operating table. His mother came to me, and after long discussion, I accepted the challenge only because I had in background of my mind that I have Aquadex ultrafiltration system available. And I thought that probably I can manage him few months on this and then take the challenge. So I accepted the challenge to replace one valve, which was pulmonary valve. I repaired another one, which was tricuspid valve. I resected the very large aneurysm of the right ventricle, and the patient recovered very, very well. And if you see his cardiac MRI, cardiac cath, and coronary angiography, liver fibroscan, liver biopsy, upper GI endoscopy, CT abdomen, CT pelvis, to assess the heart, liver, and kidney, you will be surprised how badly his all the organs were affected. Recovery therapy for improving the condition of his heart to increase the chances of success for fourth-time redo surgery in presence of liver and kidney failure, needing multiple medications for keeping him alive was a big challenge. Then, as I said, I came to know about the aquapheresis. The machine and kits were immediately supplied in our hospital. Patient and relatives were explained about the procedure and benefits. So dialysis and CRRT was not advisable. In fact, it was tried, didn't work. The pressure was always less than 80. And then we started this on September 2020. Aquapheresis was done in ICU and continued for a few days. His condition markedly improved after losing few liters of fluid from the body. His kidney function improved, liver function improved. He was almost euvolemic. And then repeat echo shows the size of the IVC came down to 20 from 36 millimeter. Ascites became minimal, BP improved. The intravenous pressure in the IVC and CVP fell down. Renal perfusion naturally improved. His renal output also improved. He started responding to even smaller doses of diuretics. He was also started on sacubitril valsartan combination, Vimada. Overall, his pre-admission status of 109 kilo was reduced to 83 kilo. Earlier, this technology was not available, I think, in India, but after 4 months of medication, he lost some good amount of volume and weight, and his condition also improved, all parameters. And in fact, the aquapheresis was restarted to again improve his condition preoperatively. We removed 7 kg of extra fluid, and which added again some good response. So on 12th February, he underwent 4-time very high-risk third redo surgery, which consisted of excision of the right ventricular outflow tract, which was a huge. Then we replaced the valve, and post-operative period also used the Aquadex. So this is how it was. This is the huge aneurysm which was excited, and after that, this is the aortic valve. This is the aortic valve which I use in the pulmonary position. In conclusion, such magnitude of complex redo open heart surgery 4-time was probably not possible without the help of Aquadex. I have a very small clip. I won't take so much time, maybe just 1 minute. This guy has left a message. Yeah, here you go.
I, Mr. Samir Pramod Shah, residing currently in Meera Road, Mumbai, India. In early childhood, tetralogy of Fallot's was diagnosed and I was operated for the same in USA. Mitral valve stenosis was operated in Chennai Hospital. In 2020, I was suffering from severe heart failure due to the leakage of pulmonary valve from my previous surgery of tetralogy of Fallot's. Also, the tricuspid valve was severely causing leak and secondary effects on my liver, kidney, and liters of water was getting accumulated in and around my lungs, liver, abdomen, and both legs. So much so that I was admitted in ICU for several days. Dr. Nandkishore Kapadia Director, Adult Cardiac Surgery, Director, Heart and Lung Transplant Unit, Kokilabin Dhirubhai Ambani Hospital, advised me to get shifted to the hospital, where he will try a new technique of Aquadex ultrafiltration to remove water and will do next to impossible, very high risk 4-time redo open heart surgery. As my extra water came out, my weight was reduced to 20 kilograms and bleeding from both my legs, varicose veins also reduced. On 16th February 2021, I underwent redo replacement of pulmonary valve with repair of tricuspid valve after a large weak area of my right side of heart was repaired. I was very scared with the 3rd time major surgery on my heart, as it was extremely complex and high risk surgery. Now after 4 months, I have completely recovered and joined a new job. I am thankful to Dr. Nandkishore Kapadia sir and his team, nursing staff of Kokilabin Dhirubhai Ambani Hospital, Mumbai, India, for giving me new lease of life.
So sorry if it take a longer time than I thought, but this was very important to stress the use of this system. Any questions? I think we can take once Dr. Chakravarthi finishes his presentation.
Thank you, Dr. Kapadia, for this enlightening session. I know that a lot of us will be enriched with this deliberation of yours. Now I welcome Dr. Rajasekara Chakravarthi, who's a well-known nephrologist. He's a member of KDIGO on AKI 2018-19, member of AKIN and ATQI, member of AKI, Committee of International Society of Nephrology, committee member of International CRRT Conference held in San Diego since 2005, reviewer of Indian Journal of Nephrology, Indian Society of Nephrology, Indian Heart Journal, and Journal of Indian College of Cardiology. Organized and co-chaired 17th ATQI conference at Hyderabad on management of AQI in developing countries, proficient organization of AKI and CRRT conferences since 2005, published more than 75 publications in national and international journals, and presented nearly 125 presentations in various conferences, both national and international acclamations. Now I request Dr. Chakravarthi to please proceed with his session.
Thank you, Namita. And it was very good to hear Dr. Nandkishore. What I'm going to convey would be actually a repetition of what he said. So keeping the time factor in mind, we would go through a little fast. As Dr. Nandkishore shared with us, ultrafiltration in heart failure is here to stay. And you and I, who are going to manage these patients, have to learn how to go about doing ultrafiltration. Very briefly, I will share a gentleman who was a hypertensive and recently recovered from COVID pneumonia and was actually shifted to a rehabilitation center. One of the reasons to have been shifted to rehabilitation center was his close kith and kin were all in the US, and he needed support, and he was in the rehabilitation center. He developed some sort of a hypoxia there, and with atrial fibrillation and fast ventricular rate and hypotension, he was brought back to the hospital. So these are the details I will not go into, but he was hypotensive and required some amount of inotropes. There was definite pulmonary edema. Subsequently, we realized that he was having some form of a myocarditis, and his repeat COVID antigen was also positive. After correcting the electrolytes and intubating him, keeping him in the ICU for some time, almost 3 days, we realized his hypoxia worsening was because of a right pneumothorax, and there was an ICD placed. And subsequently, he started developing some acute renal injury, which was worsening over a period of time. Part of it was because of drugs like colistin. So he had myocarditis with global hypokinesia with severe LV dysfunction, and his pro-BNP was 3,331. He was managed with antiplatelets, heparin, diuretic support, and we were not getting him any better, and his supports were also increasing. The sepsis was addressed, but in spite of being on ventilator, inotropes, then heart failure management, he was not getting better. He was grossly fluid overloaded with a serum creatinine of 2.7. Please keep in mind, a gross fluid overload will underestimate the serum creatinine because serum creatinine also is diluted. At this stage, we decided to put him on a Aquadex therapy for aquapheresis, and he was subjected to 3 days around 9,000 ml of ultrafiltration. As soon as we could decongest him, he started improving. I have a video, but that's okay. He started improving his lung parameters, his hemodynamics, cardiac output, renal function, all of them started improving. And shortly after this, we could shift him back to the rehab center, and he is doing well, including walking there at this point in time. The serum creatinine, when we sent him back to the rehab center, was 1.1 milligrams per deciliter. So if you look at this particular therapy in a patient like this who had a massive fluid overload state, 9 to 10 liters of volume, and all other organ systems to some extent are compromised because of the fluid overload. As Dr. Nandkishore clearly explained, when you have a central venous pressure going up, your renal vein pressure also goes up, causing new onset acute kidney injury. You don't need any other reason except fluid overload, what you and I understand now as an abdominal compartment syndrome. So any modality wherein you can remove volume in these type of patients helps you to get the patients off the supports, off the ventilator. So he did explain clearly the good things about Aquadex and good things about CRRT. As he mentioned, these are two very good modalities, and you should be well versed with using both of them, and they are complementary to each other. There are certain patient populations in whom CRRT, CVVH, or any of the others is useful, but just for ultrafiltration, you don't need to put somebody on CRRT, and you could use a therapy like Aquadex. The other details of fluid overload state and how to manage the machine also he has discussed, including the blood flow, circuit, and the anticoagulation. I will skip all that and conclude with something like, when you have a fluid overloaded patient, you should consider whether this person needs solute clearance or not. Does he need a urea clearance or creatinine clearance? In that case, you would like to use a ultrafiltration modality with also some amount of diffusive clearance, wherein you could choose a regular hemodiafiltration or a CRRT. But if the patient does not need a solute clearance, that is when you will consider only scuff or something like aquapheresis, where Aquadex would be a major thing. Even if there is renal failure, both in the patient that Dr. Nandkishore shared and also what I showed you, the renal failure here was secondary to the amount of cardiac failure. So when you do an ultrafiltration and achieve good amount of ultrafiltration over a period of time, renal function also improves. As he mentioned, liver function improves. As you decongest the system, you get increasing cardiac output, increase in liver function, and increase in the renal function. So with that thought, I would like to share, this was a paper that we had published in Indian Journal of Nephrology, ultrafiltration by peritoneal route in refractory chronic congestive heart failure. So working with a large group of cardiologists and cardiac surgeons, we had very often landed up in a situation where heart failure was bad and we had to initiate dialysis because of worsening renal function. What is now called as worsening renal function secondary to heart failure. So this is a situation where it's a little complex. You start these people on regular dialysis or any diffusive modality, their residual renal function also drops over a period of time. And one of the major understandings that we have now in heart failure of any etiology is there is a significant amount of inflammation that is accompanying or associated with heart failure. So in the literature, it's very clear now, there are a group of cytokines called as myocardial depressant factors, including interleukin 1, interleukin 6, and TNF-alpha. Very high levels of these circulating cytokines further cause myocardial depression and other organ dysfunction. So when you have somebody with heart failure, there are a list of things that you can do, but as Dr. Nandkishore discussed, most of them cause more and more ROS activation, more and more sympathetic activation, which is actually one of the pathogenetic factors in heart failure. You don't want that to happen. And the only thing that can actually mitigate increasing ROS and increasing sympathetic stimulation is a ultrafiltration therapy. Even the diuretic therapy, there are elegant studies available wherein they themselves can contribute to renal failure. I will not go into the mechanisms due to lack of time, but we should know there are limitations to use of these diuretics, especially when the heart failure is worsening and it is chronic. So there has been enough literature about ultrafiltration. These were the 3 trials after 2005, rapid CHF trial, Unload and Euphoria, which talked of safe, effective weight loss, significant weight loss, and preserved renal function when ultrafiltration is used. And all of them talked of early ultrafiltration. But unfortunately, when you start doing it by any other route, that is extracorporeal route, there is some amount of stress in the cardiovascular system, and sometimes that drops the residual renal function. We are used to doing peritoneal dialysis in a cardiac surgery patients and heart failure patients also. So this particular paper I mentioned talked of peritoneal route ultrafiltration. So we had more than 67 patients in whom we tried it. The reason why I'm bringing this up here is in many units, doing a peritoneal route ultrafiltration is not feasible. Whereas if you have access to a system like Aquadex, just like peritoneal route ultrafiltration, you will not be causing a drop in the residual renal function. And with a filter like the Aquadex filter, you are able to still remove the myocardial depressant factors, wherein you can achieve what we could achieve using a peritoneal route ultrafiltration. So without going into details of the study, I would like to mention that our experience has been using a cycler initially and then the patients going home with a peritoneal route ultrafiltration. Heart failure patients can be given quality and quantity of life improvement, and whatever the objective was to get them out of the hospital. And one of the most significant thing was these levels in some of the patients, we could actually measure interleukin 1, interleukin 6 and TNF-alpha, and found that from 1000 in the circulating levels, they come down to double digits like 10 or so. So I am convinced today that when you have a patient with heart failure, you should be in a position to offer ultrafiltration. And we achieved it by using peritoneal route, and we are just developing some experience with Aquadex system. I believe Aquadex system can replace the peritoneal route ultrafiltration in this group of patients. And what we found was there is a change in functional class in heart failure. Once they are on ultrafiltration, because the myocardial depressant factors improve, their heart failure classification, NYHA class also improves, their NYHA grade improves, hemoglobin to our surprise improved significantly. Subsequently, we found in the literature, when you have myocardial depressant factors circulating, there is a bone marrow suppression also, which is taken care of as you do ultrafiltration. Of course, the renal functions improve and the patients actually get more responsive to diuretics subsequently, which they were resistant to before the start of ultrafiltration. And the most significant change was the mean days of hospitalization, number of days of hospitalization, pre-ultrafiltration and post-ultrafiltration, and the improvement in the ejection fraction leading to patients' quality and quantity of life. So I'll stop there. thanking Dr. Nandkishore for spending a lot of time on this modality. And I believe in India, with the number of heart failure patients that we have, we should be comfortable using these therapies and giving them a new lease of life, both quantity and quality. Thank you.
Thank you very much, Dr. Chakravarthi. It was great to have your experience, and definitely these patients, those who are having a renal involvement as well as cardiac involvement, as Dr. Kapadia mentioned, this could be a definite revolution in these patients, a paradigm shift to the fluid management. Sincere thanks to both of you, sir. Now we can take it ahead, Namita, if we have questions.
There's one question that has come. What would be the right BP to put patient on Aquadex therapy? Sir, I think Nandkishore, sir.
Yeah, see, there is nothing like right BP or wrong BP. The thing is, most of the cardiac failure patients who have hypertension, in spite of the fact they are on inotrope, even if the blood pressure is about 75 to 80, which can be suitable for putting Aquadex, which may not be suitable. No technician, dialysis technician will dare to do dialysis, hemodialysis with this blood pressure. They will immediately stop. But the ultrafiltration in a very, very small quantity to begin with, it can be done even at the pressure of 75, 80.
Thank you, sir. The other question is, why do we need Aquadex if we can remove fluid overload through peritoneal dialysis?
So as I showed, we are very comfortable doing peritoneal dialysis in some patients, but we find that in people, for example, the particular patient that I discussed and Dr. Nandkishore discussed, they don't need it again and again. Peritoneal dialysis or peritoneal route ultrafiltration is good for patients who have chronic heart failure, whose heart is not going to improve. And you can put a PD catheter and send them home with a PD prescription, wherein there is a loss of volume every day, or sometimes we have used it once a week or twice a week. But those who need it acutely, when they are in the ICU or in a CT ICU, you don't need to put a PD catheter and train them on it. You can just do a session. I shared you, we could remove 9 liters in less than 3 days, and this patient subsequently could walk. So that is what probably the place of Aquadex in the therapy of heart failure. When you need it for long term, wherein your heart is not going to improve, surgically not amenable, you may still consider after few sessions of Aquadex, somebody going home with a peritoneal route ultrafiltration. But for in acute situations wherein you need volume removal over a period of time and patient needs to move out of ICU or go for a procedure like Dr. Nandkishore took, it is a very important area which can be filled with a system like Aquadex.
Yeah, just one comment that Aquadex doesn't reduce the importance of the nephrologist, because the nephrologist doing dialysis, hemodialysis, and many times peritoneal, of course, peritoneal dialysis will be always there. What Dr. Chakravarthi was trying to say that for acute situation, we have a handy tool now, which can help us to manage these patients even with the low blood pressure.
I agree with sir. There is no level of BP wherein I would not try a ultrafiltration modality, because the pathogenesis of hypotension in that group of patients is volume overload. And as you remove volume, you actually expect their blood pressures to start improving and the inotope requirement to come down.
Thank you so much, Dr. Chakravarthi and Dr. Kapadia. I think we don't have any more questions. So now I'll request Mr. Laurence to say a few words from the.
Thank you, and thank you for the very nice presentation, Dr. Kapadia, Dr. Chakravarthi. Sorry, it was very interesting and reflecting actually what we see also abroad. And what I just would like to say in conclusion is that we see all over the world, we see more and more patients with heart failure coming to hospital, with this acute decompensated heart failure phase and staying in hospital for very long. And what is really rising, it's the fact that if you go with a technology like the one you have been listening so far, with ultrafiltration, with simple way of ultrafiltration, you definitely see the length of stay of the patient, which is dramatically reducing. I don't know in India what the length of stay. Let's say, for example, in Europe, we have a length of stay for acute decompensated heart failure patient, which is an average of 12 to 14 days. And the one who are really diuretic resistant may stay 3 to 4 weeks in a hospital and get out of the hospital with still some extra fluid. And we see that with a therapy like this ultrafiltration, this aquapheresis, you can really get your patient out of the hospital in very good condition in terms of weight in 3 to 4 days. So that's really something that people start to appreciate, because it allows to get patient outside the hospital very quickly. And then it's also regarding rehospitalization. So it's a dramatic change in terms of rehospitalization. Hypothesis is that the decongestion with ultrafiltration is superior to the one with diuretics, which allows the kidney to work again in a far better condition, which avoid a rehospitalization for the same problem very soon. So if you look at just these 2 points, we see outside, I would say not outside of India, but in the rest of the world, we see that there is more and more interest now for that. And also, if we look at the clinical proof, I wanted to mention a meta-analysis which has been published some months ago from Dr. Wober, who has been looking at all the randomized control trial made with ultrafiltration and showing definitely a wide benefit. The article title was "Ultrafiltration is better than diuretic therapy for fluid overload acute heart failure patients." This meta-analysis over 800 patients demonstrates that ultrafiltration increased fluid removal and weight loss, reduced rehospitalization, and decreased the risk of worsening heart failure. So this would be my conclusion here, and I'm very glad to see that also in India you are now starting to use ultrafiltration for your patient, and that's good, and I'm glad. And thank you again for the nice presentation.
Thank you, Laurence. So now I'd like to offer a vote of thanks. So it is my utmost privilege and honor to offer vote of thanks to eminent and learned speakers and guests. We as an organization are highly obliged for the interest in the topic and time granted to us out of your busy schedule. My special mention would be for Dr. Nandkishore Kapadia and Dr. Rajasekara Chakravarthi for swiftly enthralling us into the idea of treating fluid overload through ultrafiltration and improving the life expectancy of patients. We hope to get enlightenment again and again, not only on mentioned topics, but also on many such more. Thanks a lot, Soma.
Thank you.
We hope that everyone is enriched.
Thank you.
Thank you so
Thank you, Laurence.
Stay safe.
And thank you,
Thank you,
everyone.
sir. Good night. Good night.
Bye.
Thank you, Dr. Chakravarthi.
Thank you.
Laurence, for being with us. Thank you, sir.
Thanks.
Recording stopped.
Yes, Nitish, finally, what was the number?
48.